Thank you. All right, we'll start the session. So thanks everyone for being here. Thank you, Dr. Ko and Dr. Thuli. I don't have any financial disclosures relevant to this talk. So I want to highlight this topic on post-refractive surgery ectasia. Um, well, if someone has lost their phone, please. Okay, that's fine. All right. Okay. Let's get back on track. The incidence, reported incidence is 0.04 to 0.6%, mostly post LASIK. There's a possibility that this is a rare entity, but there's also a possibility that this is underreported. Approximately half the cases will present within 1 year after the surgery. Of course, it's a devastating complication for someone who had 20/20 vision before the surgery. Most cases are reported after LASIK. PRK is the safest procedure. And SMILE, there are some cases reported. We really have to wait and watch how things go. Presentation of ectasia can be subtle. This is a pentachem of a patient who had LASIK many years ago and has some, suspicious topography, but it can be really right in your face. This is a patient who has post-LASIK ectasia, and the first presentation was high drops in post-LASIK ectasia. Of course, she got better with just conservative management, and you can see the side of the scar where there was decimate steer. The histopathology is no doubt it's similar to keratoconus. There are breaks in the Bowman's membrane. There is slippage of the interlamellar and interfibril collagen, and there are large interlamellar clefts. So very similar to primary ectasia. Risk factors, the number one risk factor is abnormal corneal tomography, and that is why we are seeing a reduction in incidence of post-refractive surgery ectasia, because everybody has become very, very, very careful with screening these patients. Young age, low residual stromal bed thickness, low preoperative corneal thickness, high myopia. You see, all these are related to each other. Enhancements, so I have to tell you, over the past 5 years, whatever cases I've seen with post-refractive surgery ectasia, they've had more than one procedure in the eye that had ectasia. So enhancements are really, it's a good point to ask in history. You can actually calculate the percentage of tissue altered, which is basically, it tells you how much tissue has to be ablated in relative to the corneal thickness, and based on a paper from back in 2008, this is a good metric. If the PTA is 0.4 or more, it's not a good sort of case to proceed. Some risk factors maybe are asymmetry in tomography, chronic eye rubbing, family history of keratoconus, which we really take very seriously. If a patient has a definitive history of ectasia in the family, I would really counsel the patient and most likely will not do the surgery. And unstable refraction, which is a no-brainer. Clinical presentation basically is progressive, asymmetrical, inferior corneal steepening with corneal abrasions. There will be a progressive, slow decline in visual acuity and deterioration of visual function and change in corneal tomography over time. This is a physician who actually presented in 2008 with some suspicious tomography, elected to wait. In 2010, you can see it's almost clear the patient has post-LASIK ectasia, had enhancement only in this eye, left eye was fine. We offered cross-linking. Patient decided to wait, and 2 years later it got worse, and 4 years later they just kept on getting worse. Finally, in 2019, when the patient had a significant reduction in best corrected visual acuity, they actually proceeded with collagen cross-linking. You can see some subtle signs. This is a patient who has likely got unilateral corneal ectasia, 26-year-old, bilateral refractive surgery done 4 years ago, apparently thin cornea but mild myopia, had blurring of vision only in one eye, the left eye, and this is how the barometer, the Galilei can look like. Management options, you can use contact lenses, collagen cross-linking, and corneal transplant. We'll discuss each one of them. Contact lens fitting, the biggest advantage, of course, it's non-surgical treatment. It can be expensive depending on where you live, where you practice. There's also a problem in this treatment option. This does not affect the progression of the disease. So that's one difference between a 60-year-old with keratoconus, where you can almost sure the patient is not going to progress, but a 60-year-old with post-refractive surgery ectasia will most likely progress. So its contact lens sort of come towards the end for visual rehabilitation. They cannot be the primary treatment. This is how a patient looks like in sort of a post-PK keratoconus post PK after post LASIK ectasia, but still progressing. Another example of a 52-year-old patient, LASIK done in 2003, approximate pre-op myopia was minus 9.75, visual acuity was worse than the right eye, and that's how the right eye looks like. There is slight sort of steepening you can see on pentacam with K2 values of 45.7. Cross-linking was done in this eye. We do use alcohol-assisted delamination. You have to be careful that you do not dislodge the flap. So the removal of epithelium is actually away from the hinge. You can use standard Dresden protocol, half an hour soak, followed by half an hour of UV. If you have a different machine, you can use a 20-minute soak and a 20-minute UV as well. There are different protocols available. There is a need for corticosteroid eye drops, mainly because these patients can have increased incidence of DLK after surgery, and you might need to keep the BCL for a relatively longer duration because of the epithelial defect. So that's how the patient looked like pre-op, and this is post a few weeks after cross-linking. That's how the vision looks like. 6 weeks was 20/60, 3 months 20/50, 6 months 20/50, and refraction at 6 months actually got the patient back to 20/20 best corrected. Patient has been stable. 68-year-old patient, LASIK done in 1999. Progressive worsening of vision, left eye, bilateral pseudophakia, YAG cap done. Treated for dry eyes, for blurred vision. Oculoplastics saw the patient for evaluation of lid tightening. They thought the lid is actually quite floppy. That's what the patient can't see. Patient was sent to us. We did a pentacam, and that's how the patient looked like in that eye. No enhancements. K2 was already 49 diopter. Pinhole vision was 20/200. Contact lens trial was done. Visual acuity improved to 20/30. We were happy. 68-year-old, looked pretty good 20/30. 10 months later, patient comes back, massive progression. This is a 68-year-old. Normally you would tell a patient, you're too old, it's not gonna progress. Good news that you're old. So patient obviously progressed, and we did cross-linking in this patient. Just an example again, it might not stop progressing. For patients who are beyond the level of cross-linking because of thin cornea, you can do a large penetrating graft. Of course, there's a risk of rejection. You can do a large lamellar graft. Of course, there are challenges in thin corneas. You can use femtosecond assisted dissection if that is possible. This is ages ago when I was a resident back here in RP Center, described this technique of tuck-in lamellar keratoplasty, which is actually nothing but mushroom keratoplasty, but because of absence of femtosecond lasers, we used to develop the flange ourselves. So this is just a schematic showing central lamellar graft, but the periphery 2 millimeter is actually thinner than the central graft. So you can see here in cross section, you basically tuck it in and you suture it in a way so the periphery is actually strengthened more in these patients. You can use this technique in advanced keratoconus, in post-keratoplasty recurrent ectasia, and also in keratoglobus or PMD. This is a patient, an example, who had tuck-in lamellar keratoplasty. You end up putting about anywhere 30 to 36 stitches in these patients. So cross-linking extra, where you can combine collagen cross-linking with LASIK or PRK, aims to strengthen the cornea for high refractive errors and thin corneas, but there is no definitive evidence that this is going to protect your patient lifelong. So the best way is to prevent by doing corneal tomography using a reliable device. So to conclude, post-refractive ectasia is fortunately a rare complication. Corneal tomography is the best modality for diagnosis. Management depends on severity of ectasia and state of progression. Contact lens fitting is an excellent option in stable corneas, not progressive corneas. Collagen cross-linking definitely works. Keep an eye on your patient if you're not doing collagen cross-linking, and if you end up doing a corneal transplantation, you have to resort to special techniques. Thank you very much for your attention.
Thank you, Vishal. So is there any question or comment from the audience?
Yeah.
I know you have to leave, so we won't ask you too many questions. But with post-LASIK ectasia, how, so I had a patient who was 26 when she got the LASIK, 300 micron bed. The only thing we could find in her was that she was hyperextensible. Do you, is there any studies that, do you routinely check for hysteresis when you do?
Yeah, so we do check, we have access to Corvus. It's not approved by the FDA. We have it in sort of a research project. You can, I mean, so if there's a history of hyperextensible joints, I'm sure it wasn't done at your center, but we usually have that question somewhere in the questionnaire. And I would definitely avoid doing surgery in such patients. But yes, if the question is corneal hysteresis, you might not be able to pick up much, although Corvus is quite good. Somehow it's better than Pentacam in certain situations. That's a whole other talk. But yes, so we do corneal hysteresis in our
On everybody.
pre-LASIK patients. Okay, any other questions? Well, thank you very much.